Welcome to the International Palliative Care Network 2012. My lecture today is a talk about the influence of goals of care on suffering. And my name is Laurel Herbst. I'm a physician with 32 years experience in palliative medicine, trained in hematology, oncology, and internal medicine. I recently retired from 32 years as founding medical director of San Diego Hospice. And I was a founding member of the American Academy of Hospice and Palliative Medicine and served as its president in 1996. I have no conflicts or funding sources. When you talk about medical goals and human goals, two questions arise. On one hand, what are the sources of suffering? And how do we determine what our patients' goals of care might be? We think of suffering as pain, vomiting, shortness of breath, headaches, all kinds of problems, physical problems. But we also talk about something being a pain in the neck or somebody being a pain in our behind. We deal with things with regret when we have a broken heart, unfinished business, cares about our loved ones that may very well influence our pain or our vomiting or our shortness of breath. Because we've all seen people who are anxious have more problems with their physical symptoms. Maslow's hierarchy is a simple mechanism to try to understand some of the sources of suffering and begin to explore with patients their needs and goals. Abraham Maslow was a psychologist who was basically set out to help employers get better work out of their employees. How do we set up a workplace so that employees can do their jobs better? And he described that they need physical equipment. You might need tools for your job, or a phone, or a desk, or a window. That there were safety needs. You had to know your job was going to be there tomorrow, but you also had equipment that protected you from flying glass or that the punch press wasn't going to cut your hand. You had to feel part of the community. He called it love and belonging, that esprit de corps that they develop in many companies where everybody was proud to work there. Esteem needs. Your employer needs to tell you when you're doing a good job. It's hard to keep doing a good job if all you get is criticism for when you screw up something or do a bad job. So it's really important in a workplace to hear when you're doing it right. And then he talked about self-actualization as those self-starters that just seem to create everything out of their own minds. When we apply this to palliative medicine, it's very simple to see how we can look at sources of suffering falling into some of these same categories. Our patients, no matter what illness they have, are dealing with physical issues. If they have cancer, there may be pain problems. If they have dementia, they may have function problems. Everybody gets weaker. Ultimately, they get bedbound. There are symptoms of fluid and nutrition problems, sleep disorders, as well as the usual array of nausea and constipation and weakness and those kinds of things. So what would you think of as safety needs in a patient? Well, the obvious is don't fall out of bed and don't let the house burn down around you. But there's also the safety of knowing what's going to happen. So often, the biggest problem a patient will have is not understanding the process of the disease. Either they haven't gotten the results of tests back, or they haven't been told what's wrong and they're afraid, or they don't know how much pain is going to get worse. They want not to be abandoned. We have so often seen patients whose doctors couldn't help them, so just didn't help them at all. I can't cure you, so go away. So I think we have to be able to listen to our patients about their plans, their advanced care planning, what they've thought about for the future, what their hopes are. Then in terms of love and belonging, we're all members of a community. There are really very, very few true hermits in this world. We all live in families, societies. We belong to clubs, or we belong to gangs. We belong to dance groups, or we belong to churches. We're part of a larger community. And those communities are affected by our illnesses, and those communities affect our illnesses. So in a loving, caring family, when a patient is sick, everybody rallies around to help care for the patient. But then we know that not all families are loving and caring. Some of them have problems. In the U.S., we call these dysfunctional families. Somebody's on drugs, somebody's in jail, somebody's beating somebody up, somebody's stealing money. All those things can make the physical problems the patient's having much worse. As one becomes more ill, one's role in the family changes. If you're the mom and you can't cook dinner anymore, you begin to feel like your self-esteem is drifting away. Everybody wants dignity. Everybody wants some self-control over what they can do for others. And some of the issues of anxiety and some of the issues of fear come out of the fact that you lose your role. You lose your job, and then you can't get out of bed without help. That's pretty difficult. Some of the things that we can do to improve patients' esteem and dignity is to, for example, be on time for our appointments with them. Very simple. Not keep people waiting in the waiting room. Call them by their name, the name they want to be called. I've described before that there is a study that was done of elderly women in nursing homes, and there was a high level of depression. Most of these women were in the nursing home because their husbands had died and the families didn't think they should live alone. And the depression was found to stem from the fact that they weren't called by their names. They were called Honey or Dearie or maybe Susie, but they'd been identified as Mrs. John Smith or Mrs. Jane Smith for years. And not being called Mrs. Smith made it feel like they weren't being identified as themselves anymore. So I think calling patients by their names, being on time, keeping our commitments to them, respecting our patients can do a lot to restore that sense of dignity and esteem, even when we can't make the illness better. If you look then at the last level of Maslow's hierarchy, we have taken the self-actualization category and said, gee, that seems more like issues of meaning and value, the things that are spiritual in our patients, not necessarily religion, although religion would fall into this, but it's that your doctor just told you you've got 6 months to live and you walk out the door and it hits you, I'm going to walk off the end of the earth into blackness, and that scares me because I don't know what's going to happen. That's spiritual pain. That's what we identify as spiritual pain. So each one of these levels of Maslow's need can affect each one of the others. If you have severe physical pain out of control, it's very hard for somebody to restore your self-esteem. And if you have spiritual fear, it's very hard to get your physical pain in control. Let me tell you about Michael. He's a great example and a patient I learned a lot from. Michael was a 44-year-old man who came to the hospital where I was working in the hospice with severe pain in his abdomen. He had liver cancer that was a result of hepatitis C, which he got from IV drug abuse many years before the cancer developed. And he was homeless and destitute and a pretty miserable guy the day he came to the hospital. He had pain he rated at 9 or 10 out of 10 on a 0 to 10 scale, and just didn't seem to have a lot going for him. We threw big doses of morphine and other opioids into him, trying to get his pain in control. And the best I could do was maybe down to an 8 on a good day. And this went on for several days. One day I decided I needed to talk to Michael a little more. And I sat down with him. I said, is there something else bothering you? Is there something going on? And he kind of sighed and he said, yeah, I wish I could talk to my sister and ask her to forgive me. And he, told the story of having been abusing drugs while he was living with her and her 2 small children, and she'd thrown him out because he was a bad influence on the kids. Then finally, he left and they'd lost track of each other, and he said, "We haven't spoken in 12 years. I would like to tell her how sorry I am about all that." So I said, "Where's your sister?" And he had no idea. We put the social worker to work, and they found her in another city. Called. She didn't want to talk to him too much, but finally, with some encouragement, we were able to get her to call him on the phone. And they had 2 or 3 phone conversations, and she finally hopped on a plane and came to San Diego and was with him for a whole afternoon. Many tears were shed that afternoon, and lots of hugs. And he told me later that, she'd forgiven him. But the most interesting thing to me was that when I talked to him about his pain, it was down to a 5. Just right. No more change in medicine dose. Just down to a 5. After a couple more days, it hadn't gone any lower, and I thought I had figured Michael out. So I went back in and I said, "What else, Michael, is bothering you?" And well, I was born and raised Catholic. And I went to Mass every Sunday, and the priest said if I didn't go to Mass on Sunday, I would go to hell. And I haven't been to Mass since I was 12. So I'm going to hell. I understood that might make anybody feel pretty badly. So we were able to get one of our Catholic priests on the hospice staff, who was a chaplain, who understood both about the spiritual suffering, but also about the physical relationship it was having. And he spent several hours with Michael and was able to give Michael the rites of the Catholic Church that indicated forgiveness. And Michael's pain went away. By the next day, it was 0. Never did come back again. No change in his pain medicine. And finally, he lived for about 2 weeks in the hospital. And when he died, the next day, all the nurses on the floor got individual bouquets of roses from Michael. And what he'd done is arranged with the florist to be notified by his sister when he died so that he could say thank you to the staff for their care and their love during the end of his life. So he was an example of physical pain made far worse by fear, by family problem, by his lack of self-esteem, and by his spiritual problems. And none of those things would have cured themselves. They required the interventions of specialists who understood how to ask what was wrong. The social worker, the priest, the nurses, the doctors, all were important in his recovery. It wasn't just about giving him enough morphine to knock him out or otherwise, sedate him. When we talk medical goals, we physicians, we often are talking about things like code status, full code, resuscitation. Are we talking about curing the disease? Are we talking about a remission is possible? We clearly want to ameliorate symptoms, but sometimes we go for the cure rather than the symptom improvement. And we can ask ourselves questions. Can we learn anything from this patient? Is this patient appropriate for a study? Are there things that are about this disease that are new or unusual? And sometimes we are trying to avoid specific interventions. Perhaps we think the patient's too weak to undergo a surgery, or some other issue that we really don't want to do something for the patient, even though the patient may be saying, "Go for it, do everything." When we talk to people about human goals, they don't seem to have a lot of relationship to the medical goals. People will talk about 3 big categories: living to a target, finishing something or accomplishing something, or a relationship. Kinds of targets I've heard from my patients. I want to live until my granddaughter's born in 2 months. I know it's a girl already, and I want to see her before I die. Well, my grandson's going to graduate from college next month. I'd like to live that long. I can't die at Christmas. That would be terrible. Let's wait till after Christmas. I don't want my family mourning me during a holiday. Practical issues. I had a patient when I was an intern who said, I can't die until next Saturday because that is the first day that my wife will be eligible for my pension, and if I don't live till Saturday, she won't get any money. Very practical issues. Religious issues. In my belief system, one should never give up. Some people think that there may be punishment in another world, and some people see suffering in this world as atonement for something they've done wrong. So all of those are possible targets that would cause people to want to live. Maybe they want to finish something. I'm writing a book about the history of something, and I've got all the research done, and it's going to take me about another month or two to get this book done. Or I have all these photo albums that I got to get some labels on because my family won't know who in the world all these people are. Or I have to tell the story of the family migration through one country to another to my grandson, because otherwise nobody in the family will know how we got here. There may be other financial things. I got to clean up the will. I want to leave an ethical will. An ethical will is a moral instruction of how you want your children or grandchildren to live their lives. Or I need to transfer the assets. Or I need to get a durable power of attorney appointed. Some of those things are really critical to people. We talk to them about get your affairs in order, but we're really very specific with them. There are also relationship issues. Imagine the issue of sorrow and fear a 35-year-old mother dying of ovarian cancer might have if she's leaving small children. Is there grief over loss? Remember, we have all thought about, how we grieve for other people who've died. But when we think about it, a person who's terminally ill is grieving for losing everybody at the same time. So there are some real relationship issues for a lot of these people. So how do we decipher and decode? We all learn to read. Somewhere along the way, we learn to decode those letters and figure out that when you put them together, they made words, and we could then decipher what it was saying. So when we're deciphering and decoding the messages from patients, one of the primary tools is inquiry. Patient says, I don't want any surgery. Well, what does surgery mean to you? What do you think will happen? What would you like to have happen? And what are you thinking about? What's in your head right now? What's the primary thing going on for you? Be gentle. This is not the time for you to advocate in disguise. What are you thinking is very different than what are you thinking. So be gentle, understand the nuances of your tones. If you can develop these questions and begin to understand what makes this patient tick before there's a crisis, you can have a greatly solidified doctor-patient relationship. You'll be trusted. It's a great touch point for revisiting goals. And then there's this magic phrase that you can use in the practice of medicine at any time and all the time, which is no matter what you're doing, give both possible consequences to the patient so that you can say, if this happens, we'll do this. If that happens, we'll do that. If we get a CT scan and your tumor is smaller, then we can move on to this maintenance therapy. If the tumor is bigger, then we will go on to this stronger therapy or a second-line therapy or whatever. And you can include later on, then we will be looking at palliative care. Then we will be trying to refer you to a hospice program. Culture is the effect of socialization. We all live in a culture of some sort. No culture is all right or all wrong. They're just culture. They just are. They're how you were brought up. Some of them are stronger in some areas than others. It's just the way it is. Socialization is influenced by so many things. It's environment, food sources, religious beliefs and practice, customs, laws, and external forces such as enslavement, occupation, and individual parenting variations. So you cannot put people in boxes by where they were brought up or what country they're from or what race they are. You have to think about them as individuals. We have a phrase that we were learning to avoid, basically, when I was retiring, which is to avoid cultural imperialism. It's this sense that you can know what somebody's going to say by how they look or where you know they're from. And we don't want to act on stereotypes because people change. People acculturate as they change from one place to another. Not everybody was brought up the same way, even in the same culture. And there's intergenerational changes that happen. What you do need to learn is what the kinds of cultural beliefs that could affect your conversation are. One that I've run into in the community I live in is there's a large group of people that believe that a doctor would never discuss code status if it wouldn't work. That I wouldn't bring it up and say, do you want us to try to restart your heart if it stops, unless it would work. Well, we all know that it doesn't work most of the time, especially in the face of a terminal illness, and yet I am required by law to ask these patients. So I do need to understand that the people who are in this cultural group who believe that I wouldn't bring it up need to have a different explanation from me about what I mean, so that I can say to them, we need to write something on paper. This isn't going to help you, but I need for you to understand the consequences of saying no. That kind of conversation goes on all the time. One of the other ways you can get clearer about how to deal with really end-of-life issues, especially this code status stuff, which is so variable among cultures, is to be inquiring of your patient early on, how are medical decisions made in your family? Who should I be talking to about your medical care? And who should be here today while we talk? Now, if this average Midwest American woman is sitting in front of you, she's going to say, you talk to me, I make my own decisions. Fine. But you may have someone whose belief system is different. We tend to grow up in two basic kinds of cultures: individualism, and then where the family or social base is the most important. In my Native American population, the Native American cultural base is more important than any individual decision. It's the good of the tribe or the good of the family. So it's important that we understand that as we're trying to make these medical decisions. Who should be here today while we talk? It may be whoever's going to make the decisions. It may be that you will have already been told by somebody in the family not to talk to the patient about what's wrong. And in that case, you need to do a lot more inquiry about, is this strictly cultural, or can we ask, how sick are you? I find that when I have been told, don't tell the patient how sick he is, I'll go in and say, how sick are you? Well, I'm dying. Did anybody tell you? So I think patients know more than their families give them credit for. But we don't want to disrupt their structure of the family unnecessarily. So it's always done with inquiry. We need to respect the value of people's beliefs. Humans are seekers of truth. And real truth maybe give rise to multiple interpretations and cultural norms. If you think about orienteering as a sport, that's where you try to find a place on the map by coordinates. It requires three perspectives. You need to come at three different directions, and where the lines intersect, that's where you want to go. If I look at truth from a Southern California, USA perspective, and I learn what truth is from somebody in Central Africa, and I learn what truth is from somebody in central China, I may be closer to the truth than any one of them separately. So, opening questions. Remember we said about if-then being magic. What do you remember why we did this test? What do you remember about why we did it? If the answer is appropriate, you can give the results of the test. It might be good news or bad news, but you know that they remembered what you said. If there's totally off base, if it's totally inappropriate, then you need to do a lot more coaching. So, the ER doctors always tell me, yeah, but I have old patients I never see before. I've never seen before, probably won't see again. You got a brand new patient. Looking at the situation, you might want to try a ridiculous question. Here's an example. You have a 96-year-old woman who comes in to have a physical, and no particular illness other than she's just getting old. Everything's wearing out a little at a time. Start to talk about code status, and you get this blank stare about what are you talking about. And you realize that this patient has never had a discussion like this before. So you could try the ridiculous question. You say to the patient, are you going to live another 30 years? Well, if the patient says, I hope not. Ask, well, what are you hoping for? The patient says, well, I hope so. Then you can ask, what would you hope for if that can't happen? You see, there are no wrong answers here. They're just going to reveal what the patient wants. There's a Buckman protocol to deliver bad news. It's pretty simple, kind of a few steps to it. Create the right setting. Know the answers, the lab tests and all that before you. Don't be sitting there in front of the patient looking things up. Make it quiet. Get the right people there. Remember I said, who should I be talking to? Do you remember why we did the tests? Coaching through the information. And then the thing to really remember is that when you give bad news, there's an internal storm of adrenaline that happens to a patient. It does not matter how prepared you think you have made that patient. The adrenaline will flow like the saber-toothed tiger jumping out of the cave at the caveman, so that the patient from then on hears nothing, doesn't know what you're saying, can't hear you, you're blanked out. So you need to wait for that to calm, because what you don't want to do is leave the patient in that situation without a plan. So you wait till the patient's calmer. And it's really hard. We doctors don't like to be sitting with people who are crying or yelling at us. We like to be doing something. We tend to talk more than we should in those moments. So if you can learn to be peaceful and just say, I'm here for you, and wait for the adrenaline level to calm down. It takes about 10 minutes most of the time. Then you have a plan with the patient. I'll see you back tomorrow, or we're going to do this today, or whatever the plan is. But never let the patient go without the plan. We all have patients that seem to be difficult, uncooperative, non-compliant. We use the term non-compliant in a fairly derogatory way a lot of times. Oh, the non-compliant patient must be doing something deliberately to make me mad, obviously. Walt Disney had a great approach. He had a management workshop that he teaches all of the people who work in the parks, is when you got a person who seems to be off the wall, either angry or abusive or abrasive, use the approach, what would have to be going on in my life for me to act that way? If you've got a difficult patient, an uncooperative patient, try that to develop the empathy, because once you understand which one of Maslow's hierarchical needs isn't being met for that patient, you can then, with your empathy, intervene and help the patient feel better or get through a hard place. Why should we care? Why should we care about whole person care? Well, when I went to medical school, the first thing I was told on day one was, first of all, do no harm. If I'm going to go put a patient through a therapy that is going to make him very, very ill for the next 2.5 months and not find out that his driving desire is to finish his book. And if I give him that therapy, it may not get done. I will have done him harm. So first of all, do no harm demands that we know what our patients want and need. Medical outcomes improve with good palliative care. People live longer, they feel better, they're more compliant with therapy. We've got studies to show now that early lung cancer patients referred quickly for palliative care consultation live twice as long as the people who didn't have it until the final end of their life when it was clear that they were dying. Attention to the goals of care also improves patient satisfaction and generally overall lessens suffering, both for patients, their families, and for you as the doctor on call. Whole person care, then, is a sum of the biology, culture, and physiology of each patient. Consider an interface with integrative medicine when appropriate, especially when the allopathic or osteopathic medicine is failing. Integrative medicine can make people feel better. There are some evidence-based developing that some of these treatments can reduce anxiety, can reduce nausea, can make people feel more valued. So, whatever's available to you in your communities, whether it's hypnosis, acupuncture, or some examples. I think the most important thing to remember is that whole person care is about developing a relationship with your patient, and that what we really want to do is make people feel better because they live longer and our outcomes are better. Thank you very much.